So I already started your introduction
In Portuguese.
in
Yeah.
Portuguese,
Yeah.
and Professor Alex Vitkin is from Canada, from Ontario, and he's closely related to the group of Brian Wilson that was here for 10 days, right? And as Brian, Alex has a broad interest in biophotonics. So his interest goes probably beyond the lectures he's going to give. And I visited his lab and I had opportunity to talk with him. He's very interested in some of the things we are interested, like using losses of polarization in tissues for evaluating something on the tissue. I don't know if you involved that in your
Yeah, I think
talk,
the talk tomorrow is going to be on that.
But
Excuse me.
so he's a permanent faculty there, and very nice laboratory, maybe one of the best in the world, that group of laboratories in Canada. And I would like to encourage students and faculty members and everything to talk with him. He's going to be here for a few days, and I'm sure you'll be willing
Absolutely.
to hear people
Yeah.
suggest making contacts. And of course, all the production, if you go to his homepage, you can see everything he's doing much better than I can speak. He's going to give a sequence of 3 lectures, and then he's going to give a talk in São Paulo in the workshop we're organizing there together with the hospitals in São Paulo. So I hope you enjoy Alex. I hope Alex enjoy us here.
I'm sure that'll be
And
fine.
we can have a few days of nice exchange.
Thank you very much. So, yes,
You need a pointer?
laser pointer?
Or laser
or
or rigid?
physical pointer? Mechanical pointer.
I have a metal.
Oh. Oops. I can use my finger, yeah. Okay, well, thanks very much, Vanderlei. Unfortunately, I don't speak Portuguese. I only speak English. So I'll try to speak slow, and hopefully most of you can understand. But please, anytime during the talk, interrupt, have questions, comments. Don't just save it till the very end. Again, it's a pleasure to be here. I've been in Brazil. This is the first time I've been to Brazil. First time I've been south of the equator. So I spent the first 4 days in Parachi. Yeah, so it's very nice. So now the fun is over. Now I have to do all the work. Thank you very much. So as Vanderlei mentioned, I'm from Ontario, from Canada. And hopefully, as we interact a little more, maybe some of you will develop interest in coming to visit us. And in the summer, it's very hot, but like this. But in the winter, it's very cold. So there's pros and cons to that. So what Vanderlei asked me to do is just to give you some ideas of what kind of research we do. So I decided to concentrate on 3 different areas that we're doing research in. So today I'll concentrate on optical coherence tomography, a way of imaging tissue using kind of high resolution optical imaging subsurface. And specifically talk about Doppler optical coherence tomography. I'm sure you know what that is. And in the context of what we're doing here, this is for imaging blood flow. So microvascular blood flow in tissues. And so this is where I come from, University of Toronto, U of T. And the hospital where I work is called the research hospital called Princess Margaret Hospital, or University Health Network is a larger set of hospitals. Some of you, certainly Vanderlei, have been there, and it's a big kind of biomedical convergence facility of universities, hospitals, companies, and so forth. And this is another organization in Ontario that supports lights and optical research called Photonics Research Ontario. Again, if you have any questions, comments, or issues, please feel free to say something. It's okay?
Yeah, we have to get a chair.
Couple more chairs?
Yeah.
I was going to sit in this one, but no. Do you want one back there? Or is that enough
Yeah, maybe somebody will come
for another one?
You became too popular,
So now I have to stand for the whole hour. Okay, so before I get into Doppler OCT, I just wanted to set the stage a bit where I am. So I guess we're here, and I'm from here. So about 11 hours north. The flight is about 11 hours. So this is Canada, and this is the star. Does anyone, by the way, know what these little blobs on the map are? Does anyone have an idea what those little geographic formations are?
Where?
The 1, 2, 3, and there's 2 more covered here. These are the 5 lakes, the Great Lakes in North America. So we're big lakes. So we are on the shore of one of the lakes, Lake Ontario, and this is where the star is. So it's a fairly big city, not by San Paulo standards, but I guess by San Carlos standards. 5 million people or so in Toronto. English and French and a lot of other nationalities. So it's really like United Nations in Toronto. Very, very popular destination for many immigrants. It's the capital of Ontario, Canada's largest province. And if none of this makes sense, it's very close to Niagara Falls. So people know where Niagara Falls is. So that's where Toronto is. Specifically where we are is in downtown Toronto, close to the universities and close to all the hospitals. So this is just a blow up of that section. Not very relevant to you if you haven't been there, but just to give you an idea, there's a lot of hospitals, mouse imaging centers, a lot of other hospitals, the big university, the provincial government, and other hospitals. So there's a lot of biomedical concentration of activity where we are. And this is just some pictures illustrating what that looks like. So specifically our group, let me just give you an idea of what's involved there. So Vandelay mentioned Brian Wilson is the head of our laboratory. And there's 4 or 5 professors, including myself. Some of the names you may or may not be familiar with, but another professor does a lot of optical imaging and breast transillumination spectroscopy and lab on a chip and PDT dosimetry, etc. Lothar Lilg. Myself, hopefully you'll get to know over the next 2 or 3 days. We just hired another faculty member who is an expert in nanophotonics, so quantum dots and nanoparticles, and actually is a biochemist who can make those things. So our lab is pretty big, about 50 people in total if you count all the postdocs, graduate students, undergraduate students, clinicians, scientists, and these are the range of disciplines that we're pretty strong in. Most of us are physics and engineering background, optics background, including myself. But we also have a lot of biology expertise. I believe you had Dr. Stuart Bisland come here, so he's more on the bio side or kind of the life sciences side of our group, and we have a lot of people like him. And we have a lot of clinical translation. And in fact, right now, in combination with National Science Foundation, we're putting together a web portal called biophotonicsworld.org, which describes some of the stuff that's going on in the world, but it's using part of our laboratory as a test case for describing biophotonics to the world. So in the context of your outreach or your diffusion program, maybe this is something that would be of interest. So this is just some characteristics of what we do. A lot of our stuff is very based on clinical translation. So we do a lot of fundamental stuff, but at the end of the day, we have to be accountable to the research hospital as to what clinical impact our work has made, if any. So there's big emphasis on going from so-called bench to bedside and clinical translation. And so although I'm based at the Ontario Cancer Institute, so everything mostly is around cancer, we're now going much beyond cancer in a lot of our research, so things like regenerative medicine, infection, stem cell, which links with this regenerative medicine. Image-guided therapeutics is a big program, which again is partly for cancer and partly for anything else. So it's kind of a big thing. Again, if you have any questions, comments, suggestions, or if my English is incomprehensible, say so right away. Don't wait. So again, before we get into specifics, just give you some ideas as to big research themes in our lab. So probably separate into 4 areas. So using light to diagnose tissue, different imaging and spectroscopy approaches, some of which I'll talk about. Using light to treat tissue, and there we do a lot of work on photodynamic therapy. Brian Wilson is one of the demigods or gods of PDT in the world, so he's very well known and very famous for it. We also do ILP, so-called ILP, which is interstitial laser for photocoagulation or thermal therapy, and I'll talk a little bit about that. We have a fairly large program through this Photonics Research Ontario on actually making devices based on some of the research we do. So things like lab on a chip, or some customized fiber tips that we do for Doppler, OCT, etc. We try to work with companies and generate medical toys or medical devices, medical gizmos. Also, we have a large program on optical diagnostics, specifically in endoscopy, so gastrointestinal endoscopy and cardiopulmonary endoscopy, and I'll show you some examples of that. On the imaging side specifically, so kind of zooming in on one of the boxes on cancer imaging, so we do a fair amount of small animal imaging and spectroscopy and again, preclinical models, things like fluorescence, bioluminescence, Doppler OCT, some advanced microscopies and macroscopies being developed. Fairly big push on endoscopy, again, upper and lower GI and pulmonary tract as well. And this is a big thing where we're trying to now put in the diagnosis and the therapeutics together. In fact, in the States, the big funding organization called National Institute of Health, NIH, now calls this convergence of diagnostics and therapeutics theragnostics. It's a big buzzword, it's a terrible word, but it's getting a lot of play, and that the whole idea is if you're, for example, in the context of optics, if you're using optics to diagnose or to monitor something, why not at the same time treat with the same optical intervention? Perhaps optical, perhaps other. So why force the patient to have a separate diagnostic session, a separate treatment session, and a separate follow-up session, maybe several weeks apart? Why not converge them all together? So we're trying image-guided or image monitored or image-activated optical therapies, as well as beyond optical. So we're looking at thermal therapies and surgeries as well. So we're getting into these different areas. Okay. Just to give you an idea of where we are in the clinic in terms of some of these imaging characteristics and imaging approaches. So again, image-guided photodynamic therapy and now photothermal therapies. We have a lot of clinical trials and a lot of company interest in seeing how to take this to the clinic, specifically for the prostate. So we have large programs for PDT for the prostate and local therapies, photothermal therapies. And that involves actually not only prostate, but bone metastases. Not only we're significantly expanding beyond optics, both in the therapeutics and diagnostics. We have a very strong medical physics community in our university, in our hospital, in Toronto in general. So we're looking at such things as volumetric CT, MR imaging and spectroscopy, different contexts of light dissymmetry, et cetera, and collaborate with quite a few universities and hospitals across North America as well as the world. This one I'll talk about a little more detail. Doppler, microvascular imaging OCT for gastrointestinal endoscopy. Also doing some work on Raman and fluorescence. Fluorescence-guided image surgery specifically for the brain. This is when you do surgical resection of brain tumors, but you don't know if there's residual disease left. So can you do fluorescence imaging or fluorescence spectroscopy or fluorescence hyperspectral imaging to see if there's more that has to be taken out before the surgery is closed? And some other programs we're starting. Any questions, comments so far? Everyone can kind of understand what I'm saying, or a little bit?
Most fully understand what it is.
You can, but I'm asking everyone else, right?
Yeah, I can see the faces.
Yeah, I see faces. I don't know if they understand, though. Okay, so that's the general kind of overview, setting the stage. So I guess what I want to do for the next half hour, an hour, depending on how much interest and time we have, is talk about a specific program that we have quite a few students and postdocs and clinical people involved in, and that's using optical imaging, specifically microvascular optical imaging. Doppler optical imaging, or OCT, is the specific approach we'll use. Does everyone know what optical coherence tomography is, or have heard of it, or most people? Some?
Make a general introduction.
Okay. So basically, before I explain how it works, I'll just give you the subcharacteristics of it. So it's a method of doing microscopy in tissue, subsurface, without taking the tissue apart. So it's microstructural, and as later on we'll add the microvascular component, but it's basically high resolution subsurface optical imaging using interferometry, using optical interferometry, kind of a classical Michelson interferometer. I'll explain to you how that works. So what it gives you is micron scale subsurface tissue imaging in vivo, so you don't have to cut tissue apart. Those of you who may know medical physics, other applications such as ultrasound imaging using sound or using mechanical waves, this can be thought of as the optical, or at least the near-infrared analog of ultrasound. The physical principles are quite different, but in terms of signal processing and in terms of what you get out is somewhat similar to ultrasound and to Doppler ultrasound. So in addition to the high-resolution microscopy subsurface, you can also get microvascular information using the Doppler effect. And I'll show you a little bit how that works. And so the bottom line is you get microscopy-like structural and functional images up to a very shallow depth, unfortunately. So you cannot use OCT to see very deep. You cannot see through the whole body or through the whole elephant or whatever you're imaging. You can only see 2 or 3 millimeters deep. But you can see it very high resolution. So it's kind of like microscopy. So I guess in my talk I'll concentrate mostly on this, which is kind of exciting, the ability to do functional images in vivo using microvascular effect. So Vandalay asked me just to briefly explain how OCT works. So this is a very simple cartoon. Those of you in physics would remember a Michelson interferometer used to measure the speed of ether, wind, and the motion of the Earth in the stars, etc. You probably remember that from first year physics, and it was a very negative experiment, but it was a very positive result at the end of that negative experiment. So this is the equivalent of that for tissue imaging. So what you do is you have a specific type of light source, which is kind of like a laser, but not a very good one. So it's got many colors, and it's got a large divergence, and it's not very monochromatic, and therefore it acts as effectively as a bad laser. So it's a low coherence laser. And if you split the beam with a beam splitter, send part of the light to the tissue to be interrogated and part of the light to a reference mirror, which is fully reflective, and then see what comes back in the detector, then what happens is when the 2 beams that come back from the mirror and from the tissue are at equal distances from your beam splitter, then you get constructive interference. You get this kind of sine squared pattern that you probably remember from maybe first year physics. And what happens if the 2 interfaces that you're imaging in the 2 reference and sample arms are different, then that sine square pattern dies away. So you basically get like 2 DC intensities adding up. So you're adding amplitudes versus adding magnitudes. So instead of getting sine squared, so what you do physically in tissue imaging for OCT is you have this reference mirror and you move it to different depth in the tissue. So as you move it here and vibrate around this location, it's this interface in tissue that gives you little interferograms. You move it to this location, vibrate it here, it's this depth in the tissue corresponding to here that gives you a little interferogram. So by moving this up and down, you get a depth scan or a depth profile, which registers as little squiggles. And the amplitude of the squiggles is the tissue reflectivity, and the location of the squiggles in depth relative to where you move the mirror is the depth at which that reflection takes place. So you do this back and forth, and you get a line, very much like an ultrasound echo, that gives you reflectivity as a function of depth in one line. And then you move the tissue aside and do that again, and you get a second line, and you build up an image. So that's roughly in one simple explanation how OCT works. When you put a real system together, it's much more complicated, but there's a lot of optics, electronics, optoelectronics, digital signal processing, etc. But for the purposes of now, this is probably good enough to explain how it works. Does that make sense to people? Yeah. So again, to compare this with ultrasound, I guess this is more for medical people because they're very familiar with ultrasound and less familiar with OCT.
What about just to
Yep.
the light source for OCT?
Mm-hmm.
It's any laser light source, or you
No,
need specific coherence properties?
Right. It's mostly non-laser light sources. A light source, which is like a laser, will form somewhat terrible OCT images because this interference fringe will, you also have speckles, correct, but also this interference fringe, because the coherence length is so long, you can mismatch this by centimeters or even meters, and this interface will still coherently interfere with this location. So the whole idea is to do coherence gating, such that the coherence length is very short.
Shorter than the resolution you want, right?
It determines the resolution, actually. The coherence length is the measure of the depth resolution, the axial resolution. So if you have a laser pointer, which is rather coherent, then you move this here, every single interface up to that depth will still form interference fringes, and you'll get a very complicated pattern. So what you need is spectral bandwidth of the order, say, of 50 to 100 nanometers, and a central wavelength which will penetrate tissue, so red to near infrared. So typically the light sources we use in the pictures I'm showing, for example, here, this is the central wavelength, so 1300 nanometers or 1.3 microns. And the spectral width is about 70 to 100 nanometers. And a lot of the work we do now is on source development, which will still fiber couple the light, which will still have the right wavelength, but will have a much broader wavelength spread. So ultra high resolution OCT uses things like continuum generation and white light continuum, and have spectral width of the order of 300 nanometers. But that light becomes very difficult to control. You can't fiber couple it well, and those 300 nanometers are not a nice Gaussian spectral shape, but are very noisy, so your point spread function is very messy. You have to account for that. So there's issues with light sources.
How about the intensities you need?
Yes, the intensities you need.
Intense,
No, the intensities are very minuscule. In fact, if they're very intense, then this cannot be used as a diagnostic device because it becomes a therapeutic device. So the typical intensities of the light sources that we use are of the order of 20 to 30 milliwatts. So several milliwatts. By the time you get to the business end of the probe that's imaging the tissue, it's of the order of milliwatts to maybe several milliwatts to a fraction of a milliwatt. So it's in the milliwatt range.
But then you probably cannot use a lamp, right? Just a lamp source.
A lamp source you could, if you could. Well, for most clinical applications, certainly for endoscopy, you have to fiber couple it. So fiber coupling a lamp is tricky. If you're doing surface imaging, so free space, you can certainly use a lamp. Yeah, so the light sources, you need a spectral width, you need a central wavelength in the red to near infrared. You need, hopefully, fiber coupling for clinical applications. And you need, at the source output, say, 30 to 50 milliwatts of power. That's ideal. Because by the time you couple it through the network, all the losses, part reflectivity, it's going to be much less at the probe end. So again, just to compare this with ultrasound imaging, so this is one of my graduate students, not cutting his finger, but just showing where the imaging plane is. And so this is high frequency ultrasound, and the ultrasound echoes coming back. This is kind of the speckly pattern you get of the nail root of the finger. This is structural OCT, so you can see the dermis and some of the vascular structures and the nail root. Much better in terms of resolution, but of course the price you pay is it's much shallower. You don't see very deep. So this is this part blown up in the yellow box. And in addition, if you do Doppler processing, which I may get into if you guys are interested, in the same way as you do Doppler ultrasound, in addition to structural ultrasound, you see these color patterns, and those correspond to vascular blood flow. So if you can quantify those, you can actually see microvasculature, and that's very important. And clinical people are very excited about this. In fact, much more so than they are about seeing structure, especially in the context of early disease diagnosis or treatment monitoring, because structure really doesn't change that much, but the microvasculature, the blood flow, changes significantly. So that's kind of the summary of OCT. So it's higher spatial resolution ultrasound, better velocity resolution in Doppler mode, but it's much shallower penetration, of the order only 2 millimeters or so, or 3 millimeters sometimes in tissues. Okay, so this is just summarizing what OCT has as a potential imaging context for biomedicine. So a lot of excitement, a lot of papers on this about how it's in vivo in situ histopathology, or sometimes even called optical biopsy. Through the Doppler extension, you can not only see structure at high resolution, but function as well. It's, for the purposes what I'll discuss about, it's compatible with endoscopy, which is very important. Non-invasive, it's harmless. There's no dose penalty, for example, compared to X-ray imaging or repeated mammography or X-ray imaging, etc. Relatively speaking, it's fast, cheap again compared to things like MR imaging or even high-frequency ultrasound imaging, and it's fairly portable. On the limitations, this is probably the biggest one. You're not going to see through the whole body. So it's relatively superficial or very shallow imaging. So you have to choose applications where seeing 2 or 3 millimeters at very high resolution is actually important to you. So ocular applications in the eye are obviously an example of that. And endoscopic imaging or gastrointestinal imaging is very important now as well. And we actually have a method of seeing deeper, and I'll show you how we develop that later on. Fairly limited field of view, although that's changing with some of the new advances in OCT using very fast OCT imaging, so you can see larger areas by moving the probes around. There's issues with contrast resolution, and of course, any new imaging technology in the physics or engineering end looks great, but you have to decide whether there's any clinical value and clinical utility. And that you can only do by working with clinicians and seeing real clinical problems. And I'll show you how that works. Right, is it worth it? So hopefully it is, but we don't know yet. A couple of slides as to why we're pushing the Doppler aspect so much. Everybody is very happy about OCT microstructural imaging, but we think in a lot of applications that's missing the main point. Higher microstructural imaging is not going to give you a lot of clinical validation, at least in the cancer problem. And the reason I say that is there's been a couple of studies indicating that as imaging resolution of various techniques improve, we're going to detect more and more cancers. And that's because more and more cancers seem to be present in all of us. But the issue is that most of them are fairly benign. There's nothing to worry about. They're just false positives. And it's only very few that actually are anything clinically or diagnostically significant. So there's been quite a few studies. For example, these are very interesting. So these are people who die of things like car accidents or disease-unrelated causes. And when you do biopsies on them or autopsies, it's discovered that nearly 40%, for example, of women in their breasts have quite a few lumps, quite a few small lumps. But only, since the incidence of cancer diagnosis is only 1%, so it's very few of those that actually go on to develop cancers or malignant tumors. And the same actually with prostate. So basically, most women and most in their breast and most men in their prostate have dormant cancers. And so if we just push on the imaging resolution improvement, we're going to detect more and more of those, and there'll be headlines in the newspapers about cancer epidemic and more cancer and more environmental issues. But there may be nothing to worry about in the sense that only 1 in 40 seem to become malignant. So we need a different marker, a different method of identifying which ones are going to go on to become these malignancies. And so microvascular marker seems to be a big determining factor in clinical medicine. And that's, as the previous picture shows, as you go from there to here, that's when that 1 in 40 really takes off and becomes a real clinical medical problem. So the malignant progression begins when you get the so-called angiogenesis. That's a big term that's quite important right now. And so the challenge becomes is, can you identify this process? Can you characterize it? And can you find out when it happens? And the reason it's important to monitor microvasculature, as you probably know, that in the malignant tumors, or at least in tumors in general, is very different from so-called normal vasculature. So this is kind of electron micrograph showing the more chaotic and unpredictable nature of tumor microvasculature. It's also very important that normal microvasculature is much more responsive, much more adaptive, changes much more to treatments or to environmental factors than the tumors ones. So if we can see microvasculature in general, and we can see the difference in this, then it's very important for cancer imaging, cancer diagnosis, and also cancer therapy monitoring, because then you have something that will change with treatment, or will change differently from normal tissues. Sorry?
The normal is the left one?
Yeah, let me just go up. Yeah, this is the normal, and this is the more chaotic tumors.
And that's mainly because of the random.
Yeah, because the tumor ones form very quickly and very chaotically in response to different tumor growth factors, tissue growth factors. So they are not homogeneous in distribution. So the outside of the tumor has more than the inside. Yeah, there's more loops, some with dead ends. The flow is more turbulent, more unresponsive. So the tumor vasculature, for example, if you raise the temperature, will stay roughly the same. Where
It's
this
also to do with the architecture of the
yes,
tissue. Right?
it's
I mean, in a normal tissue, it's more regular.
right,
You have irregularities at short range and long range.
right.
Now the tumor, you lose the regularity at
Correct.
short range. And
Yeah.
long
So
range,
exactly this kind of disorganization at the tissue level translates itself into disorganization at the microvascular level, both in terms of how the blood vessels look, and more importantly, how the flow in the blood vessels changes. So it's a combination of those, correct? Yeah, so this is, just to clarify, this is the tumor and this is the normal. So we just kind of covered on that. Let me skip that a bit, just in the interest of time. So we would like to develop a technique to quantify the difference for normal and tumor vasculature. First of all, we need to see both of them, and we need to see the difference if we can, both on kind of how the vessels look, but more importantly, what kind of vascular flow they support. Not just how the pipes look, but what's flowing in the pipes, because that's what the tissue cares about. And there's significant implications both in the diagnostic context, so kind of early disease detection, and also perhaps more importantly in the therapeutic context. How can you monitor microvascular flow and optimize the therapy that's changing that flow? So this is providing some information as to how that may be done.
So,
Yeah.
any competing techniques to image blood flow?
Oh, absolutely. Yeah, there's a huge, actually I have a couple of slides, but maybe not in this talk. Doppler ultrasound is probably the best known technique for monitoring blood flow.
Not with this kind of resolution.
No, not at the microvascular level. Although high frequency Doppler ultrasound, which is a huge or a big research field right now, is approaching that. There is MR angiography, which is looking at diffusion more, but can be related to blood flow. So there's no direct method of monitoring in vivo microvascular blood flow except for things like intravital microscopy. But those are somewhat artificial applications because you need very thin layers of tissues, for example, the ear, and you have a big microscope to do that. So this is one of the few possibilities of actually monitoring microvascular flow at the arterial capillary level, but it's still work in progress. But this is certainly not the only approach. Given the importance of the clinical problem, there's a lot of people trying to do different things with this. So just giving you our take on it. So just to give you an idea of what the technique can do, this is a little sidestep if you want, but we use this model a lot in our research. This is a tadpole. This is a baby frog, a small frog that develops into a frog. And it's very nice because it's got very well-defined heart structure, very well-defined microvasculature, and also it's small enough for us to image through the whole thing. And there's people who are actually interested in it in and of itself because it's a big developmental biology model. So we've made some pretty interesting movies. This is the beating heart. Actually, let me just. It's got a 3-chamber heart. So this is basically imaging through right here. This is OCT imaging, so we're doing lines like this. So notice the scale bar. This is only 0.5 millimeter. So the whole field of view is maybe 2 millimeters or 2.5 millimeters by 1.5 millimeters or so, or 2. So it's relatively small, but the resolution is impressive. This is about 10 frames a second. We can do much, much faster now. In fact, I'll show you a little bit later on how we can do that. So this is just structural imaging. If you do Doppler processing, you can actually, so this is a slightly different cut. So this is not here, but a little lower. These are the vessels, the arteries leading to the heart. And so you can, again, see just the general motion. But you can also see this color-coded blood flow. This is corresponding to velocity of the blood within the arteries. This, you notice, is somewhat slower. And that's because Doppler processing needs many more imaging frames, much more imaging averages to get the Doppler signal. We can do both the structural and the Doppler much faster, and I'll show you that later on. The reason I'm showing it to you is we're developing this technology, but we need some in vivo phantom, if you want, or in vivo system to test it on before we go into patients and before we go into endoscopy or photodynamic therapy monitoring, etc. So we've been using this guy a lot and actually publishing some papers on it, which are fairly interesting, as a method of both studying it but also validating our technology approaches. So you had a question, or? Good. Right. So that was actually fairly early on when we started this program. Just another method of showing what this imaging can do. So this is another cut in the tadpole, and just to give you an idea, there's many ways to represent the Doppler information. You can look at the mean velocity. You can look at the mean Doppler shift. You can look at so-called power Doppler, or the total amount of flow. If you dig into the ultrasound Doppler literature, it's very vast. There's many ways. There's not a unique method of describing flow. You can even do so-called Doppler sonography, where you can actually hear the flow. I think I have that later on. So let me just show you what you can do in these different Doppler modes, if it works. It doesn't seem to work. Oh, there we go. No, so let's see if I can do this. So can you hear that a bit? Yeah. So that's the Doppler shift transformed into kilohertz, because it actually happens to be the kilohertz regime, which we're audibly listening to. So this is the blood swooshing in this vessel, and the Doppler spectrum of that, as opposed to mean velocity, transformed into audio. So actually this technique is used a lot in Doppler ultrasonography, when a sonographer listens to the heart and hears murmurs and things like that. So if there's any people here who know the Doppler signal from a frog heart, maybe you can hear some irregularities here. But yeah, so this is just to give you an idea of what kind of different modes of signal processing can give you on the Doppler signal. So we're using this as basically as a test bench to move on to endoscopy and other more complicated applications. So this is what I was just saying. So there's many methods to represent moving objects, blood. You can actually see. The problem is there's a lot of motion. So for example, in the esophagus and the stomach and the heart, everything moves. So how do you separate the motion of the blood wall from the blood, from the artery, from the blood itself? So there are ways of looking, for example, velocity variance, which shows more turbulence in a liquid medium than it does the solid wall in the solid medium. So you can separate so-called remove clutter. You can remove the tissue signal from the moving Doppler signal. So it's possible to separate pulsatile turbulent flow from tissue motion. So this is a benchtop validation. Now we want to move on to endoscopy, and that's what I want to go on next. So this is the two kind of clinical scenarios where we're going to talk about, I guess, the rest of the talk. So endoscopy is basically examination, light pipe examination of the, say, the gastrointestinal tract or the pulmonary tract, the inside of the body. So this is a condition in the esophagus called Barrett's esophagus. This is where you have kind of microvascular irregularities in the top above your stomach. And it's a very serious problem in the sense that in of itself is not very inconvenient. You have heartburn and you have indigestion maybe, but what happens is that it's much more likely to transform to cancer, to a full so-called adenocarcinoma, and that has no good treatment options. So people who have Barrett's esophagus are under continuous endoscopy surveillance to try to catch this intermediate step when you go from normal esophagus to Barrett's esophagus to Barrett's plus dysplasia, this is early cancer, to here. So if you can catch it here, then you have many more options. So we're trying to see if some of our work can be applied to catch this spot. And also the second scenario, non-endoscopic, and I'll talk towards the end of the talk if time permits, is monitoring therapies. So this is more kind of on the diagnostic end, and this is treatment monitoring and optimizing all this diagnostics bit that I was talking about before. And I'll talk specifically about PDT, although we're using other stuff as well. So let's talk about this first. I don't know how much you guys know about endoscopy, but as I was mentioning, it's basically looking at lamps and optical fibers to see deep inside the lining of the human body here in the colon, stomach, etc. And it's got a lot of advantages, but it's got a lot of disadvantages too. So sometimes what you see doesn't give you the whole picture, or you only see parts of what you want to see, etc. So there's a lot of research on developing new additions to conventional endoscopy. So adjuncts using fluorescence, using Raman, using OCT, endoscopic ultrasound, etc. And the reason all of these things are actually useful in endoscopy is everything happens within 1 or 2 millimeters of the lining of the endoscopic tract. So the gastrointestinal endoscopy is all these hollow cavities are very compatible with optical techniques because all the action is exactly within 1, 2, 3 millimeters of the inner surface. So the surface definitions and subsurface definitions so correspond very nicely to the sampling volume of the fiber-based biomedical optics techniques. So there's a lot of research on this, and I'll talk about OCT. So before we moved on to that, we dug quite seriously into the ultrasound literature because that's a much more developed technology than optical techniques. And a lot of their signal processing, a lot of their clinical approaches to validation and to use in endoscopy were very useful to us. So I won't go into the details, but we developed a lot of the techniques that I'll present to you based on what's been shown to work in Doppler ultrasound, specifically endoscopic Doppler ultrasound. So this was quite challenging to do because you're detecting something very high resolution. So 10 micron resolution is what OCT can do, but you're doing it at the end of a flexible light pipe, which is twice the length of this. So it's inside the patient. Everything is moving, the nurse is screaming, the doctor is running around, the patient is breathing, the patient is hiccuping, everything is happening very quickly. And at the end of this flexible light pipe, you have this OCT probe that's going to detect cellular or 10 micron resolution images, as well as use the Doppler effect to quantify motion. So if anything moves and everything is moving, you're in trouble. Everything is going to be washed out. So we have to develop very sensitive methods for very fast imaging, methods of negating block tissue motion, etc. So it took us a while to do that. It took us about 3-4 years. This is one of our probes. If I can just show you how it works. So this is the distal end of the flexible endoscope that goes, for example, into the esophagus. It has a couple of holes in it, some for light illumination and some for the surgeon or for the endoscopist to put down biopsy needles and then take bits of tissue for analysis. So we're using one of those holes or one of those channels to put an optical fiber, and then back and forth we're moving this member, and this is our OCT imaging system. So this is the fiber. It moves, like you see there, back and forth. And there's a retroreflective prism. This is all sub-millimeter to a millimeter in diameter. And then the OCT imaging is done this way, and then you form adjacent A scans this way. So this moves back and forth about 2 millimeters. And then you get a subsurface image that way. This probe is about 2 millimeters diameter. We have newer versions that are somewhat smaller, approaching 1.5 millimeters. They also have to be very flexible to be able to reach wherever we're going in the endoscopy. So,
If you use a vibrating tip, you do the same effect.
you mean if you scan it this way?
No, just make a fiber with a side collection or, and then vibrate.
Yeah, some people have done that. You need very reproducible motion to be able to do averaging of frames, so you can't have any hysteresis, you can't have any flexing. So this is much more reliable, moving back and forth. Another possibility is to do basically like a radar sweep. So do like this, 360. And then some people have combined that with pullback motion, so you get a cylinder of images. So that's possible too. There's different ways of doing the probe design. In fact, this is very tricky, very difficult to do, this kind of micro sculptured fibers at a millimeter to sub-millimeter size scale. A lot of people who do optical design work with lenses and bulk optics. Very difficult to work with kind of fiber design at that resolution, at that level. So we've been able to do some of it, but we can always do more. Yeah. Okay, so you've seen some of these diagrams before. I'll go a little quicker. So again, in our hospital, in our university, it's very important to take it to the clinic. So this is our kind of development lab, now packaged and present in an endoscopy suite in one of the hospitals in Toronto, where we do gastrointestinal endoscopy. And so here are some of the actual in vivo results. So this was kind of a world's first demonstration of this optical imaging, microvascular optical imaging in normal as well as disease patients. So these are different structural layers, lamina propria, muscularis mucosa, submucosa, etc., that you can see in vivo. And these little blobs of color are different representations of the vessels, subsurface vessels that are present. This is only 2 dimensions, and we're now working on getting this into 3 dimensions so we can see the actual architectural patterns of this blood flow. So these are 2 normal sections of the esophagus. This is this Barrett's esophagus, so you can see it's actually got more vessels, which you can also see just in white light endoscopy. And this is another disease called esophageal varices, which has much more flow, but it's deeper. So this was a big deal to do this. Now our big question is, what does this clinically mean? Does it make any difference to the doctor or to the physician? We're in the process of answering that question. So we also went and tried to do some imaging on Barrett's that transformed itself to adenocarcinoma. So this is full-blown esophageal cancer. And this is this pre-malignant condition called Barrett's. And so what we're now trying to do is to see what happens in between. Can we see this transition where the architectural layers are lost, as you can see here, the structural layers, and the microvasculature patterns change. So what we need to do is get more patients from here to there in that intermediate state between Barrett's and Barrett's with dysplasia, and then esophageal cancer. So the answer is still unknown. We're conducting those studies now. They're quite difficult to do, actually, but we're doing the best we can. And this is one of the students who did a lot of the work, kind of tired after a day in the endoscopy suite. But we didn't do any endoscopy on him. Okay, so now, is this seminar 1 hour or 1.5 hours? 2 hours. Oh, it's too boring, too long. So what I wanted to do, I know you guys do a lot of PDT, photodynamic therapy here. So what I thought we would do is talk about this Doppler OCT for photodynamic therapy monitoring. So this is not endoscopic diagnosis. This is treatment and feedback on treatment, and dynamic feedback, optimization of treatment using this Doppler OCT. So before I move to Doppler OCT for photodynamic therapy, we also did some chemotherapy monitoring. So there's a big deal in our hospital and a lot of other research places looking at so-called anti-angiogenic therapy. So not treating the tumor, but treating the new vessels that feed the tumor. So angiogenesis is this process of new vessel formation in tumors. Anti-angiogenesis are all these big drug companies are very interested in killing the blood supply to the tumor. So this is the kind of images we were able to obtain for this monitoring of this antivascular chemotherapy. This is a very big drug that's being marketed by one of the big drug companies as a means of treating tumors, not by treating the cellular aspects of the tumor, by treating the vascular supply to the tumor. So this was some of the probes we developed and ability to see in real time what happens to basically the blood flow, the subsurface microvascular blood flow, as a function of treatment time following the injection of this microvascular or anti-microvascular drug. And this was just recently published. And
sorry, the image there,
yeah.
how is that gathering? I see a fluorescence on the top of your...
No, this is a Doppler OCT image, so there's no fluorescence. So this is reflectance, and this is the Doppler signal superposed on the OCT image. So this is, and what's plotted here is basically normalized microvascular index indicating how much blood flow you have and how that blood flow changes after the injection of this, this chemotherapy drug. Does that make sense? Okay. Yeah, so this was again kind of surface to subsurface imaging, and you'll see later on how we develop kind of deeper tissue imaging. So this, as I was mentioning, this is we switched gears from endoscopic diagnosis to treatment monitoring and treatment optimization. So we're going to move on to PDT. And this is with some of our early work in photodynamic therapy. I'm not going to explain what PDT is because I'm assuming most of you know it off by heart. Very easy. So we're looking to see if we can see the microstructural changes and the microvascular changes as a function of treatment using Doppler OCT. And not surprisingly, at least in the short time we followed, which is about a day, the microstructural changes are very subtle. You couldn't really see much. They're very weak, if there are any at all, because there's just not that microstructural reformation during such short time. However, the microvasculature can be changed and quantified relatively significantly. So we were fairly encouraged by these early findings. Again, this, as you know, PDT can be applied in many different tumor systems, and there's different lights and different drugs and different recipes, how to combine light and drug. So this was just one particular photofrin using a Dunning prostate cancer model, using the intradermal right thigh. So the results obviously differ for different models, and we have much more quantification than that. But the bottom line is that not much structural change, but significant amount of microvascular change. So we went further and actually developed a whole program on PDT monitoring. So this is another set of data indicating quite interesting results. This is, I'm not sure if you're familiar with a new type of photosensitizer called 2CAD. It's more of a vascular photosensitizer as opposed to a cellular one. It's treated much quicker. There's no retention time, so you basically inject the drug and start treating right away, as opposed to waiting 24 hours or 48 hours like you would do with photofrin. The clearance is much faster, so there's no photosensitivity issues. But what we found when we did this in a mouse model and developed kind of a three-dimensional volumetric data set for this flowing blood flow fraction was that there were significant changes in the microvascular index during therapy. And if that's the case, as you probably know, PDT needs creation of singlet oxygen to work properly. And that's supplied through molecular oxygen being excited through this intersystem crossing with the photosensitizer state. So if during this 10 minutes or 15 minutes of light shining, most of the blood flow shut down, then supposedly most of this light is wasted. There's no reason to continue PDT treatment if you've shut down the vasculature. So this kind of indicates, potentially, at least in this treatment model, that this is not an optimized treatment regime, because some PDT effect is supposedly taking place here, but this, you're just shining a subtherapeutic light. There cannot be a PDT effect if there's no blood supply. So we're trying to see if these blood flow changes during and following PDT are really indicating that a lot of the light or a lot of this treatment regimen is not optimal. It gives you a dynamic method of monitoring what's going on and possibly predicting what will happen later, 2 days or 2 weeks following treatment. It gives you some ideas of what are the models, implications of treatment planning. And of course, this is, again, a result dependent on the photosensitizer, on the tumor type, whether it's normal tissue or tumorous tissue, et cetera. But again, very encouraging and relatively unavailable information previously. So again, we're pushing this further. And we also wanted to overcome what I was mentioning, one of the limitations of Doppler OCT is shallower imaging. You can get away based on tissue optics and the scattering in tissue to more than 2 or 3 millimeters. So one of the ideas was, why not develop a very thin needle and stick it into deeper tissues? So it's not non-invasive anymore, but it's minimally invasive. Like I don't know if in Brazil you guys have acupuncture, very, very thin needles that can go very deep and minimally painful. So what we did is we developed an OCT gun type of thing, like a needle. And I was told never to take this across the border because I would not survive. So basically, a sub-millimeter needle, this is 2 different versions of it, that fits at the end of a very thin sub-millimeter tube, and then can be under ultrasound guidance or X-ray guidance placed anywhere that you want to monitor microvasculature or microstructure. And then it's still only going to be 2 or 3 millimeter depth of imaging, but it doesn't have to be in the near surface regions. It can be much deeper.
So, excuse me, but when you insert the needle,
Yeah.
it's about half a millimeter diameter.
Yeah.
You create a damage
Yes,
about
absolutely.
the same amount around.
Yeah, it depends. Depends what kind of damage, and we've done a lot of studies to indicate, to test what damage is created and how much of the effects that you'll be seeing are going to be due to PDT treatment or some other treatment, and how much is due to basically you inserting the needle, like blood pooling,
No,
etc.
I'm sure you can do a differentiation.
Yeah.
This is a problem because each place, I know that like when you press tissue, you damage some microvascular.
Absolutely.
And then
Well,
it's recovering,
Yeah.
it's recovering already in my finger. So it's not that a problem for...
It's an issue. I can't say that it's not invasive, but it's an issue in the sense that even when you're doing non-invasive imaging, especially microvascular imaging, if the temperature is hot or if there's some tissue pressure, of course that changes microvasculature as well. So you have to...
No, I'm not just...
Yeah, I know, I
I'm not saying
understand.
that the technique doesn't work. I'm saying
No.
how you deal with the problem.
Basically by doing differential measurements, so by doing measurements with and without the treatment in question, and seeing what effect the technique itself has and what effect the technique with the treatment has. So kind of do control experiments. But you're right, it's a legitimate issue. So this is just what I was mentioning, some of the difficulties in making these micro fiber tip probes. So we're using something called a ball lens, and that has a very interesting characteristic. You can do both focusing and beam steering in one element. So if you do kind of total internal reflection and design this at an appropriate angle, you can do both OCT focusing and OCT deflection in one element, which is a little simpler than having a grid lens followed by a reflecting microprism. And now what we're working on is with a collaborator in the States on using microelectromechanical systems called MEMS to do both dynamic focusing, beam steering, and deflection all at the same time. But this was still a microstructured lens. And so what it enabled us to do is to answer the question whether the kind of effects we're seeing were mostly surface or near subsurface related versus deep. So we can grow deeper tumors, and we can see if some of this microvasculature is affected through PDT at a deeper level, because what we want to do eventually is to use that information to predict, for example, depth of necrosis. But if your information is only in the first 2 millimeters and the depth of necrosis is going to be, say, 7 millimeters or 1 centimeter, it's very hard to make that transition. So basically the question was, the reason the study was designed and the reason we designed this OCT gun is what's happening deep in the tumor. So this is one way of answering that. And so here's an interesting dimension. So the optics are actually about 400 microns, so 0.4 millimeters. But when you take into account the housing and the gauge where we put this in, it's still sub-millimeter. So this is 7/10 of a millimeter is our probe. This is using a slightly different optical design. Again, some micro-optics involved, and this is what it looks like. So again, some ideas of how the microstructure looks. This is as a function of treatment, and I'll show you a movie how that works. And some of the microvascular monitoring components. Again, not much changes in the structure unless you do some kind of speckle analysis or image analysis, but even there it's very subtle. But significant changes in the microvasculature. So got to quantify these things. So if you look at this movies, a little maybe less exciting than the beating heart, but maybe clinically more relevant. So this is going to basically change from before PDT, during PDT, and after PDT. So this is the structural image based at the end of our needle. This is post-PDT. This is the Doppler, the velocity, and this is the variance in the velocity, a different method of quantifying Doppler effects. So let me just wait for it to start, and we'll start before PDT. So I just missed the start, sorry. So this is a loop. This is following treatment, and let me just wait for it to start again. Right, so we have actually just 2 vessels in the field of view. When we turn on the PDT, you can see the vascular shutdown during the treatment, and then you see a little bit of a recovery following treatment. So some of the blood comes back. So this treatment, at least in this particular case, did not fully obliterate the microvasculature. There's still some stuff remaining. So this type of data, especially extended to 3 dimensions, can allow us to do quantification of the PDT progress, at least as based on this microvascular metric. So you can do things like vascular shutdown rates. So again, this is very tissue specific and treatment specific, but that of course, so is the entire treatment. It very much depends on the tissue, and there's only so much you can do in terms of forward treatment planning. Each response seems to be different. So you have to account for that, and using this dynamic feedback information is the method that allows you to account for it. So
the energy I'm seeing there is the energy you need to supply the surfaces to produce this shutdown of the vessels, right?
you mean these energies?
Yeah.
Yeah, so that's basically what's, there's different ways of quantifying kind of the subsurface fluids versus the surface fluids, but this is surface irradiation basically.
The surface, yes.
Yeah, but we have models, Monte Carlo as well as diffusion, to know what's the actual fluence at depth, fluence in the region where the probe is inserted. So the importance of quantification, you can see pictures, but we want to quantify the pictures. So pictures worth 1,000 words, but a number is worth maybe 100 pictures. So this type of information allows us to actually normalized or non-normalized get an idea of what's happening quantitatively. And we're pushing that through in the context of other PDT treatments. So let me, I don't know if I want to go for a whole 2 hours. I have some more slides, but
It's up to you.
yeah, people are probably getting pretty bored. So let me just give you some general comments. So at least we talked about endoscopy, now we talk about this small needle. So we can image possibly in deep tissues with sub-millimeter fiber sensors. So we're no longer restricted with this technique to kind of subepithelial, intraluminal, or transparent organs such as the eye. The PDT, this is quite important, the PDT effects on microvasculature are dynamic, detectable by DOCT, and complex. So there's very many parameters that can change all of these findings. The type of tumor versus the type of normal tissue, the site, the animal model, certainly the type of PDT, all of these have an effect. And it's quite important to be able to explore those effects because they seem to be differing for every treatment. So there's significant real-time feedback possibilities and potential for for other treatments for monitoring. A lot of chemotherapy and certainly most of radiation therapy, which is I do a lot in my other job in the clinic, is done blindly. In other words, you check 3 to 4 weeks to 4 months later if the treatment was successful. Is there any way of trying to monitor treatment effects in real time that you can quantify and modify the treatments such that it would be better? And that's a big, big question, very big question.
It's a real-time treatment, right?
Real-time
feedback.
Real time. Is there anything that changes that can give you information about how it's going to turn out? If the answer is yes, can you develop a technique to monitor that change such that you can quantify and feedback on the treatment during real time so you don't have to retreat? So we're currently interpreting this previously unavailable microperfusion in vivo information because a lot of people are unfamiliar with it, including the clinicians we work with because they've never seen it before. And so we're kind of bridging the gap between, in some ways, between the microscopic and the macroscopic imaging regimes. I think I just have a couple more slides. There's a big debate in the kind of angiogenic literature that says that tumor vasculature, as it's being treated, on the way to becoming killed or obliterated, actually becomes normal. And that's the window of opportunity when you should be supplying chemotherapy drugs. In other words,
Can you say again now?
yeah, I'll slow this down a bit. This is a big guy in Harvard Medical School and MIT as well, Rakesh Jain, put together this big tumor vascular normalization hypothesis that says that on the way from abnormal vasculature to basically killed or obliterated vasculature, part of the progression, you pass through a normalized or near normal vasculature. So when you give some therapy, you should not give most of the therapy at this stage because it's not going to be delivered to tissue because the tumors are not sufficiently leaky and the vessels are not properly formed, so you'd be wasting a lot of the therapies. You should do the therapy such that it's a little bit so-called normalized, becomes normal. And this is where you deliver the bulk of your antivascular therapy because this is now pretty good vasculature. And then that pretty good vasculature will become inadequate. So he's developed...
These evolutions as the time progress.
Not so much as the time, basically as the treatment progresses.
Treatment progress.
Yeah, this supposedly is the time. This is the disease formation. But if there's no treatment, this doesn't happen, these two. So it's following treatment, this is what happens. So he was saying don't give treatments here or most of the treatments here. Most of the treatment should be given at this stage. So we're trying to see with a variety of angiogenic professors and researchers in our lab and a variety of angiogenic drugs we have, if we can use Doppler OCT in vivo, in real models as opposed to window chamber models, et cetera, to quantify this disease progression. In the perfusion literature, there's a lot of debate as to whether you have functional perfusion or not. In other words, sometimes you may have blood flow, but it's depleted of nutrients, so the fact that, and depleted of oxygen, so the blood may even be flowing, but it's not really perfusing the tissue in the metabolic sense. So we're trying to see if we can combine this with things like partial oxygen saturation and interstitial fluid pressure measurements, which we have a capability of doing in our lab, to shed some light on this. On the technology side, we're working with a professor in Montana State University and at Stanford on using microelectromechanical system, MEMS, to make better tips, make better OCT probes. And one of the possibilities we can do is to make a variable focus probe. So not a fixed focus grid lens or a fixed focus ball lens, but a variable focus lens. So we can actually scan the focal length and increase our lateral resolution and different depth in the tissues. And so he's developed these membranes that change curvature. And you can change the curvature at the kilohertz level. So this is flexible membranes. And of course, if you're going to change curvature, why not also change the tilt angle? So you can scan along the lines of what you were mentioning, little Vanderlei. So you don't have to have this motion, but you can do side scanning in a very reproducible way, and you can flex the membrane. So do depth axial gating in addition to coherence gating. So this is still work in progress. But it's also possible, as I was saying, to use this MEMS for beam scanning, steering, and focusing. So we're working on that. Again, the challenge is how do you make that compatible for a thin, supposedly flexible endoscopic probe? That's a very big challenge. I was showing you some early movies of tadpoles. These are kind of more later movies. This is a much faster system, and you can see much cleaner both structural and microvascular images. And this is, again, the structural on the top, and this is the microvasculature on the bottom. And you can sort of see, or in combination with developmental biology people, we can see some structural formations and blood flow formations in the heart in the probe while it's beating. So this is now 45 frames per second. This is now using a frequency domain Doppler OCT system as opposed to the time domain, which is what I was showing you before. That's a different way of doing OCT imaging, kind of more advanced way. And you can do some three-dimensional reconstructions, including blood flow within moving objects, which is very tricky to do. Sorry, maybe I can see this better. So again, this is on a small scale. This is different structures in the heart rendered in 3D and actually 4D, in some ways 5D if you can account for the Doppler as well. And you can do some fancy stuff like fly-throughs that, again, in a moving object, fast-moving object, you can actually freeze the motion and see the filling of the chambers of the heart based on this three-dimensional Doppler information we can obtain. Again, this is partly technology testing and partly actually answering some developmental biology questions. So kind of a best of both worlds, if you want. This is a one-slide summary I had to prepare for the director of our institute on endoscopy on Doppler OCT. So if you've been sleeping for the last hour or so, this is one way to capture it all in one slide. So basically, we had to describe what the clinical issue is, and what the scientific approach is, and what the technological approach was, and what the clinical impact was, if any. So this is, I've covered most of the slides before, so I won't go into that. So what are we doing with this, at least in the Doppler OCT? So again, being physicists and photonics people and engineers, we're pushing the envelope on the technology. But we're also keeping in mind that technology itself is not going to make a clinical impact. So we're doing both technology and clinical together. So on the technology side, we're working in the frequency domain, the Fourier domain OCT, using better, broader, more powerful, better coherence light sources. Forget ultra-high resolution OCT, using this MEMS, or working on this MEMS to improve the tip performance for dynamic focusing and steering. Haven't talked a lot about lack of contrast agents. There's any self-respecting medical imaging technique always has contrast agents. There hasn't been much work done on that in OCT, and we're starting to work with that. Using different approaches, including micro and nanoshells, and using some of the new faculty members we have in our department that actually work on developing contrast agents. I was going to say, maybe, does he want to speak instead? Yeah. So we're going beyond gastrointestinal endoscopy and PDT studies to what I was mentioning before for stem cell research, antivascular drug, interventional cardiology, regenerative medicine. And it's really becoming an imaging platform for developmental biology, for regenerative medicine, for small animal longitudinal studies. So it seems to have a lot of clinical preclinical biological applications, which we're very happy about because we didn't want to just develop the technology for our own use and for publication purposes. So it's a fairly transformative, I think, technology for disease assessment and treatment monitoring, two different kind of clinical scenarios for clinical scenarios with microvascular involvement. So we're kind of excited about that. A whole bunch of people, not so much me, but everyone else did all the work. I'm just presenting people's results. And a lot of people gave money for us to do this work, although I had to write all this. And I guess that's it. So thank you.
Questions?
Yes, questions?
I have one.
In English though, right? Yes.
I see that OCT relies very much on the amplitude phase type of information. Right?
Correct.
Now, there are a lot of information about fluctuations. So as you go deep and your environment is more like, as you said, like the vascular part is very chaotic.
Mm-hmm.
It's less order, so
Yeah.
So the fluctuations of the signal, which is not in the amplitude exactly plus phase, which is the interference again, has a lot of information. But I see no people caring about correlation in diagnostics.
Right.
So in atomic physics, we do that all the time. For us, the noise is the richest part of the spectrum. But it seems that for us, again, in biophotonics, because I'm involved, we don't care. I mean, we just look at amplitude, and so we look more the, so you know what I'm saying, right? I mean,
Yeah, I sort of
why
understand.
people are not looking for other things besides amplitude and phase?
Yeah.
Maybe in an OCT spectrum, the fluctuations will have more information than we think.
Okay.
And maybe that spectral fluctuation is what you need to identify micro changes that
Sure.
you don't see in the structure, but they are there.
Yeah. That's a good question. I mean, I wouldn't say that no one is looking at it. There are people who are doing OCT spectroscopy, both for kind of compositional information, kind of biochemistry, but also looking at speckle decorrelation and kind of the statistics of photocurrent with depth. We haven't done that, but there are people who are doing that, and you're absolutely right. I mean, amplitude and phase is only looked at because it's the signal, but the absence of the signal and how the signal is degraded with depth, which is actually what limits OCT to about 2-3 millimeters. You can certainly propagate light through 5 centimeters of tissue, but it's lost its coherence and no longer forms interferograms. So the statistics of depth decorrelation are being looked at by some groups, Joe Schmidt and Stephen Beaupart and people like that. I haven't talked about it, but yeah, there are signal processing people who look specifically or try to quantify decorrelation loss first, second order decorrelation loss with depth. Fluctuation, yeah. Yeah. Other questions in English, hopefully?
Well, I have to tell you that we still have 2 lectures more, and if you shy now, you should lose that in the next lecture. So
I'll be more, yeah. I'll encourage more next time.
he has a question.
Yes.
About instrumentation, you mentioned this, you explained it quite well, the OCT technique, but how do you extract the Doppler information?
Yeah, sure. I
Both
did.
the time domain and the...
Okay, so basically you're looking at the phase. So the structural information is all amplitude, basically. What you do for Doppler, I mean, it's a bit of a misnomer in the same way it's not the right name for ultrasound Doppler as well. People think of Doppler as the change in the frequency of, ooh, and then you see a little change in the frequency. What you practically do here is you look at the interferogram in any one line, in an A line, and then you repeat that line again. So you do kind of consecutive or adjacent lines. And each line is very complicated. You get amplitude and phases and crazy fluctuations. But if there's no motion to within your noise limit, the next line will repeat that same crazy fluctuation. as that if there is motion in that depth, then some of those fluctuations will be shifted. So you basically compare adjacent lines and look at the shifts. And
Like taking snapshots.
yes, line snapshots, line shots. So I have a couple of slides actually, probably even here, but I can easily show it to you.
So it's not really looking at frequency shift.
No. You can so what you do is you're looking at the phase shift. You're looking at the time structure change as a function of depth, convert that to phase. The phase, based on how quickly you repeat this, divided by 2 pi t, gives you the frequency shift if you want to work in that. If you know the Doppler angle, which you generally don't, but if you do, you can convert the frequency shift to velocity. So there's a lot of steps along the way. But basically what you're doing is you're comparing the time structure of adjacent lines. And if it matches, however complicated it is, then there's no motion, or it's beyond the threshold of the motion. If it doesn't match, then you kind of quantify the in phase and the quadrature, you get the sine and the cosine, and all that type of stuff. I have some slides, I just didn't want to bore you with the physics or the signal processing. Other questions?
With different tissues, the depth of penetration of these techniques could be improved, like in the teeth.
Oh, in the teeth?
Just
Actually, in
to
the
diagnose the bone condition.
yeah, the near-infrared properties of bones and teeth are actually not that different from soft tissues. So I don't think it's not a technology. It's not a power level limit. It's basically the statistic of scattering, of multiple scattering, that prevent you from seeing deeper. The only exception is the eye, which is the only tissue in the body that's transparent. Yeah, so I don't think you can signal processing, Fourier domain versus time domain, etc. I think that the basic statistics of scattering, multiple scattering, will limit you to about 2.5, 3 millimeters. I think 3 millimeters is really pushing it. So it's still going to be shallow, unless you stick a needle in the tooth. A gun.
Okay, so let's thank again Alex, and tomorrow at the same time, in the same place, same channel.
And more questions?